Bismillahirrahmanirrahim. Rabbi zidni ilma. Quote of the day. The wound is the place where the light enters you. Assalamu alaikum everyone. My name is Dr. Sadia Rafiq and under the supervision of Professor Dr. Sars Mers, today my topic of presentation is SARS and MERS. Learning outline includes the introduction of SARS and MERS, symptoms, spread and treatment, epidemic, SARS, MERS and COVID-19, recent updates and multiple choice questions. Learning outcome. At the end of this presentation, participants will be able to describe SARS and MERS in detail and also the comparison between SARS, MERS and COVID-19. So starting with SARS, which is severe acute respiratory syndrome. Severe acute respiratory syndrome is a viral respiratory disease caused by a SARS-associated coronavirus. It was first identified at the end of February 2003 during an outbreak that emerged in China and spread to 4 other countries. SARS is an airborne virus and can spread through small droplets of saliva in a similar way to the cold and influenza. It was the first severe and readily transmissible new disease to emerge in the 21st century and showed a clear capacity to spread along the routes of international air travel. SARS can also spread indirectly by contaminated surfaces with the virus. Most patients identified with SARS were previously healthy adult aged, 25 to 70 years old. A few suspected cases of SARS have been reported among children under 15 years. The case fatality among persons with illness meeting the current WHO case definition for probable and suspected cases of SARS is around 3%. Regarding epidemiological triad, agent is SARS-CoV. It is an enveloped single-stranded RNA virus and infects epithelial cells of lungs. All ages are susceptible, equal risk to both genders. There's no lifelong immunity. Environment includes overcrowding, poor ventilation, humidity, and low temperature. Symptoms. The incubation period of SARS is usually 2 to 7 days, but may be as long as 10 days. The first symptom of the illness is generally high-grade fever, more than 38 Celsius, associated with chills and rigors. Other symptoms include headache, malaise, and muscle pain. Some cases have mild respiratory symptoms. After 3 to 7 days, a lower respiratory phase begins with the onset of a dry, non-productive cough or dyspnea. In 10 to 20% of cases, the respiratory illness is severe enough to require intubation and mechanical ventilation. Complications of the advanced SARS include the pneumonia, heart failure, and liver failure. Treatment. There is no cure or vaccine for SARS, and treatment is supportive and based on the patient's symptom. Controlling outbreaks relies on containment measures, including prompt detection of cases through good surveillance network, including an early warning system, isolation of suspected or probable cases, tracing to identify both the source of the infection and contacts of those who are sick and may be at the risk of contracting the virus, quarantine of suspected contacts for 10 days, exit screening for outgoing passengers from areas with recent local transmission by asking questions and temperature measurement, inspection of aircrafts and cruise vessels having SARS based on board using WHO guidelines, personal preventive measures to prevent spread of the virus into frequent hand washing with soap or alcohol-based disinfectant, social distancing, and wearing masks. For those with a high risk of contracting the disease, such as healthcare workers, use of personal protective equipment, including masks, goggles, and aprons is mandatory. Wherever possible, household contacts should also wear a mask. SARS outbreak of 2003. According to World Health Organization, a total of 8,098 people worldwide became sick with SARS during the 2003 outbreak. Of these, 774 died. WHO coordinated the international investigations with the assistance of Global Outbreak Alert and Response Network and worked closely with health authorities in affected countries to provide epidemiological, clinical, and logistical support and to bring the outbreak under control. If we see the SARS basic fact sheet or the CDC and its response of SARS during 2003 outbreak, CDC worked closely with WHO and other partners in a global effort to address the SARS outbreak of 2003. For its part, CDC took the following actions. Activated its emergency operations centers to provide round-the-clock coordination and response. committed more than 800 medical experts as support staff to work on the SARS response, deployed medical officers, epidemiologists, and other specialists to assist with on-site investigations around the world, provide assistance to state and local health departments in investigating possible cases of SARS in the United States, conducted extensive laboratory testing of clinical specimens from SARS patients to identify the cause of disease, initiated a system for distribution health alert notices to travelers who may have been exposed to cases of SARS. Now moving towards the MERS, which is Middle East Respiratory Syndrome. As it is very obvious with the diagram, if you see the Middle East means in the Saudi Arabia, Jeddah, it was started in 2012, respiratory syndrome, and it's the coronavirus. So it's self-explanatory. Middle East Respiratory Syndrome is an illness caused by a coronavirus called Middle East Respiratory Syndrome coronavirus. Most MERS patients develop severe respiratory illness with symptoms of fever, cough, and shortness of breath. About 3 or 4 out of every 10 patients reported with MERS have died. Outbreak of MERS. Health officials first reported the disease in Saudi Arabia in September 2012. Through retrospective investigation, they later identified that the first known case of MERS occurred in Jordan in April 2012. So far, all cases of MERS have been linked to travel to or residence in countries in and near the Arabian Peninsula. Peninsula is the place, you can say it is surrounded with water on the 3 sides, and from one side it is connected to the land. It is called peninsula. The largest known outbreak of MERS outside the Arabian Peninsula occurred in the Republic of Korea in 2015. The outbreak was associated with the travel returning from the Arabian Peninsula. Symptoms. Most people confirmed to have MERS-CoV infection have had 3 severe respiratory illness with symptoms of fever, cough, and shortness of breath. MERS-CoV, like other coronaviruses, spread from an infected person respiratory such through coughing, sneezing, etc. MERS-CoV has spread from ill person to other through close contact, such as caring for or living with an infected person. There is currently no vaccine to protect people against MERS, but scientists are working on it. So you can help reduce your risk of getting respiratory illness by washing your hands after with soap and water for at least 20 seconds, and help young children do the same. If soap and water are not available, use an alcohol-based hand sanitizer. Cover your nose and mouth with a tissue when you cough or sneeze, then throw the tissue in the trash. Avoid touching your eyes, nose, and mouth with unwashed hand. Avoid personal contact such as kissing or sharp cups or eating utensils with sick people. Clean and disinfect frequently touched surfaces and objects such as doorknobs. Treatment. There is no specific antiviral treatment recommended for MERS-CoV infection. Individuals with MERS often receive medical care to help relieve symptoms. For severe cases, current treatment include care to support vital organ functions. It is the healthcare facility preparedness checklist by CDC, which includes that all hospitals should be equipped and ready to care for a limited number of infected patients as part of routine operations. Potentially care for a large number of patients in the context of escalating transmission. Outline plans for administrative, environmental, and communication measures. Define the individual work practices that would be required to detect the introduction of MERS-CoV or other emerging infectious diseases. Prevent spread of MERS-CoV and manage the impact on patients, the facility, and the staff. If we see the worldwide distribution of the SARS, both and MERS, in this red you can see it was SARS. And pure yellow is MERS. And the yellow with the red dots is having both SARS and MERS. And SARS and MERS recent insight into emerging coronavirus, as you can see, the initial coronavirus is present in the bats. And so in these bats in 2002, cross-patient transmission was occurred in the palm civet and other animals traded in live animal markets. They have SARS-CoV. And zoonotic transmission from animals to man happened. And same, the otherwise the bats, then cross transmission occurs MERS-CoV in the camels. And again, there was a zoonotic transmission to the man. And then hospitalized patient, then the community contact, then the nosocomial transmission with the healthcare personnel and the nosocomial transmission with other patients. So it all went like this and led to the spread of these diseases. Now talking about SARS, MERS, and COVID-19. So you can see coronaviruses, SARS in 2003, MERS in 2012, and coronavirus in 2019 pandemic. SARS-CoV, more than 8,000 cases, 774 deaths, and in 37 countries in 2002. Then MERS-CoV, more than 2,000 cases, 858 deaths in 27 countries. And SARS-CoV-2, you can see a huge number of cases, led to 37 lakh deaths worldwide in 2019, and still we are dealing with it. If we see the virus disease, it's SARS-CoV-1 in 2002, origin was bats, intermediate host was civet cats, and the host is human. Then MERS-CoV in 2012, SARS bats, original host, intermediate host camel, and the human study. And SARS-CoV-2, which is COVID-19, again bats, pangolin. The intermediate host is still questionable. It's not confirmed pangolin because in some literature it is said it's pangolin, why pangolin intermediate host, but in some it's not. So again, the host is human. So you can see the virus origin is bat, is common. And from animals, it is transferred to the humans. Again, you can see in this way, genetically modified coronaviruses, different types of coronaviruses, natural host is bat, intermediate host is civet, and SARS-CoV, again, camels, MERS-CoV, and in its intermediate host is questionable, and it is COVID-19, and the way it is spread to the humans. If we see the MERS, SARS, and COVID-19, virus species is Middle East respiratory syndrome related coronavirus and severe acute respiratory syndrome related coronaviruses. Individuum is MERS-CoV, it is SARS-CoV-1 and SARS-CoV-2. First reported MERS was in Saudi Arabia 2012, SARS was in China 2002, and COVID-19 again in China in 2019. Current status, MERS is active. SARS, no reports since 2004. So it's a good thing. And COVID-19 is still active. Infections 2521 plus, 9,098 and 35 lakh plus. Fatality rate in MERS is 34%, SARS 10%, and in COVID-19 is 1%. Preventive and curative treatment, MERS none, SARS none, and COVID-19 none. If we see again the comparison table, then the characteristic first identified location, as I've told you, COVID-19 Wuhan, China, SARS Guangdong, China, and MERS Jeddah, Saudi Arabia. The period was 2019, still present. SARS was 2002 to 2003, and 2012, and MERS is still going on. Host of the virus, natural host is bat, intermediate host is unknown in COVID-19 cases. In SARS is civet cats or other animal hosts, and MERS is domesticatory camels. Mode of transmission is same in all, which is respiratory droplet contact, respiratory droplet contact, respiratory droplet and contact. Or not. What is this? This is gauging, basically contagious infections. It is a mathematical term also called reproduction number. So as the number indicates, it means it has more infectivity. In COVID-19, it is 2 to 3. In SARS, it was 2 to 5, and in MERS, it's more than 1. Incubation period. Median 5 to 1 days, SARS 4 to 6 days, and median 5 to 2 days. Case fatality is 3.8 to 43%, 9.6%, 34.4%. Again, we can see the comparison of 3 highly contagious coronaviruses starting from bats, SARS-CoV, MERS-CoV, SARS-CoV-2, and leading to humans. And their mode of action is to destroy, attack on the epithelial lining of the alveoli of the lungs. And then they lead the disease, pathogenesis occurs, and disease starts. Recent updates. According to World Health Organization, Middle East situation update February 22. In this highlights, you can see in the end of February 2022, there were 2,585 confirmed, laboratory confirmed cases of MERS, and 890 were the deaths. And it was about no new cases are reported during the month of February. So it's all details, and the dashboard is on the WHO website, and it is updated regularly. It is showing the trends and the number of cases and the areas which they are coming from. And on CDC, there's a complete questions, answers about information on MERS. What is MERS? Is details, differences. Can I still travel to countries where MERS cases have been occurred? So all the common questions, answers are available. If there is vaccine, there is currently no vaccine. What are the treatments? There is no specific treatment. So they have updated data, and all the information is available on CDC and WHO as well. MERS-CoV worldwide overview, it is situation updated on 12th April 2022. Since the beginning of 22, as 5th April 22, MERS-CoV cases have been reported in Qatar and no deaths. Both cases were primary cases having reported contact with camels. The last case reported in Qatar was the February 2020, and after 22 years, 2 cases came in with MERS in Qatar. Now moving towards the multiple choice questions. SARS-CoV was transmitted from civet cats to humans and MERS-CoV from camels to animals. So coronaviruses are zoonotic viruses. What does this mean? A, such viruses are confined to animals. They do not cause disease in animals. They emerge from animals to cross the species barrier infrequently. They cause pandemics. Anybody? The correct answer is C. They emerge from animals to cross the species barrier infrequently. Question number 2. There is no proper treatment for the SARS caused by coronavirus. Which of the following preventive measure is found to be less effective in reducing the transmission of the virus from one person to other? Quarantine of the infected person, travel restriction to the epidemic area, personal protective equipment for the healthcare workers, or getting a seasonal flu vaccination shot. Anyone? So the fourth, so D is the answer, which is less effective, is getting a seasonal flu vaccination shot. Tests to detect SARS-CoV are being defined and performance characteristics are assessed for laboratory diagnosis. Which of the following is not the proper specimen for the diagnosis of SARS-CoV? Nasal secretions, urine, blood, stool.
Stool.
Yes.
The stool.
Yes. Stool. Okay. SARS is contagious and sometimes fatal respiratory illness. Which of the following is not a complication of advanced SARS? Muscular atrophy, pneumonia, heart failure, liver failure.
Alpha, muscular atrophy.
Yes. Yes, muscular atrophy is not the complication. SARS is a rapid spreading, potentially fatal infectious viral disease. Which of the following makes SARS often difficult to diagnose? Mistakes in lab tests, cost of the test, asymptomatic nature, symptoms similar to common cold and flu.
D.
Delta.
Delta. Yes, Delta is the correct answer. Its symptoms are similar to common cold and flu. MERS is a zoonotic viral respiratory illness, and infected people develop fever, cough, and shortness of breath. The animal which is suspected carrier of MERS is elephant, camel, buffalo, cow, dogs.
Camel.
Camel.
Yes, camel is the correct answer. Quite easy one. Clinical spectrum of MERS-CoV infection ranges from asymptomatic to severe acute respiratory disease and death. MERS usually affect individuals who are children under 10 years, teenagers, women of childbearing age, male above 40 years, and having pre-existing illnesses.
Delta.
E.
D.
E. Having pre-existing illness means immunocompromised person. MERS-CoV is a zoonotic virus and humans are infected through direct or indirect contact with infected animals. Which of the following is not the characteristic of a MERS? Spread by fecal route, aerosol droplet transmission, reservoir in bats, or conduit to human via camels?
Alpha.
Yes, it is the correct. It is not spread by fecal route. MERS is a viral respiratory disease that was first identified in Saudi Arabia in 2012. People visiting Saudi Arabia are advised to take a MERS vaccine before travel. 1 week, 1 month, booster dose is required, not required, and not available.
Alpha.
It was just tricky question. As I have told you, there is no vaccine available for the MERS. So there is no vaccination is called because as there is no vaccine available for MERS or SARS right now. So E is the correct answer. It's not available. One of the preventive measures to coronavirus spread is frequent hand washing or use of sanitizer. And effective hand sanitizers contain at least this percentage of alcohol to kill the coronavirus and other germs of 30%, 45%, 50, 60, 70%.
60% delta.
60% delta is the correct answer.
Delta.
It is that much amount is required. This is the key, and thank you so much.
Thank you very much, Dr. Sadia. Very nice and witty presentation, I must say. Especially the MCQs, they are very brilliantly presented, and the vaccines, as they in MERS, it is not available. But we are very lucky that in COVID we got the vaccine. The question that always bothers me is why we are unable to make a vaccine against SARS-CoV-1 while we are very successful in making the vaccines against SARS-CoV-2. So the situation of the pandemic and the situation of urgency and emergency as COVID has caused SARS-CoV-2 to spread like a fire. And we have seen that the public health emergency has been declared in all parts of the world, almost all parts of the world. So this has caused this development of the vaccine to be hastened, and it is so quickly developed. And even now, when we have all the data available and the continuous surveillance systems are working in almost all developed parts of the world and many developing parts of the world, we have not seen any side effect or some concerns about the SARS-CoV-2 vaccine. However, we are unable to make SARS-CoV-1 vaccine. This may be some of the future direction where more work is required, and it leads to the development of our vaccines of more for those diseases that are bothering those areas that are not in contact with the most of other countries. So this leads to the containment of the infection to certain areas. We have seen SARS-CoV-1, as you have said, that it was more in Arabian Peninsula and then in Korea. Korea has been hit by the SARS-CoV-1, and that has increased the systems, the acceptance of the systems, and the efficiency of the systems to control SARS-CoV-2. That is why the Korea is given a lot of credit in the suppression and containment efforts against COVID-19 or SARS-CoV-2 infection. So the question is that when there is a limited spread of the disease, when there is a limited suffering of the people, then do we still have to join our hands to make vaccines so that the catastrophe in future may not happen? So these are my comments on this presentation, that it is a very good presentation. However, there are certain questions that may arise from this presentation, that why the human conscious, they are not accepting the challenge when it is not bothering the major parts of the world. So with these comments, I would stop here. If anybody has any comment or answers or suggestions or any more questions, you are most welcome to put in here. So yes, please. So we can stop here. This is a more a journal presentation because lots of material has been given, but there was not the vaccines that have been focused as one of the tool of equity, and human sufferings have not been touched in. So I think that we should also think in another paradigm of human development and equity and sustainable development goals. Thank you very much,
Thank you,
Dr.
ma'am.
Sadia. Very nice presentation.
Thank
And
you, ma'am.
mashallah, you have a very good communication skills, and especially your humor and witty nature is also reflected in your presentation.
Thank you, ma'am.
Thank you very much. Allah
Allah
Hafiz.
Hafiz.